So again, good morning. Uh, this morning session is on infective endocarditis. So we're gonna look at the definition, define it, signs and symptoms that the patients will presents with, the different organisms essentially, and then how to diagnose it, looking at the modified Duke criteria, stressing the echo features and looking at some complications. All right. So when we say infective endocarditis, what we're talking about is infection of the endocardium of the heart. And usually what is infected is the valves. However, you have to be careful because if the patient have, say, atrial septal defect or a ventricular septal defect or some other abnormality inside the heart, you might have the infected material in that location. But it is usually it usually involves the endocardium and the valves. There is a higher incidence of infective endocarditis if you have damage to the or congenital heart disease or damage to any one of the valves. So anything that can damage the valve will predispose one to infective endocarditis. So things like rheumatic heart disease, where you may get mitral regurgitation, mitral stenosis, aortic regurgitation, anything that can affect the valves, mitral valve prolapse. There's a slight increase in infective endocarditis. Bicuspid aortic valve, which is a congenital problem, and commonly prosthetic heart valves can become infected. As mentioned before, congenital heart disease, because you may have multiple defects and you can get a nidus of infection in the area of the defects. Commonly, intravenous drug abuses, because they inject dirty, they use dirty needles and inject directly from the skin without cleaning the skin. So they will overwhelm even the normal heart valve with infectious material. And of course, some of these intravenous drug abusers might be immunocompromised. And the infection usually involves the right-sided heart valve, tricuspid, pulmonic, but it can involve the left-sided heart valves as well. Pacemaker lead, foreign material in the heart, so that can become infected. And similarly, parenteral lines, if you have any intravenous line that sits in the heart, and central venous catheter, those can become infected. So what are some of the signs and symptoms? How is the patient going to present with infective endocarditis? They're going to look sick. So they may complain of malaise, fatigue, weakness, fever. Okay, fever is one of the common presentation of these patients. They come with a fever, and they are again malaise, fatigue, a new or change in murmur, and that is because if you have any infective material on the valves, it's going to prevent the normal functioning of the valve, and as a result, the valves will be regurgitant. So initially, the valve will be regurgitant. If you take the mitral valve, and if you were to see someone with acute infective endocarditis, then the valve will be regurgitant. However, if the vegetation is very large and fungating, then it can obstruct the valve. But the usual presentation is regurgitation. And weight loss. So if they have had this infective endocarditis for some time, they will there will be weight loss because it's now going into the realm of a chronic infection. Night sweats is also a common presentation. And you can get what we call septic emboli, because these infected material, if they form on the valves, you can have clotting on top of the infected material, and piece of that can break off and travel distally, and that's what we call septic emboli. So a portion of the infected material breaks off and travels distally. So, you can get a CVA, a stroke, or you can get, if it travels to, say, the bowel or the lower extremity, you can get gangrene. And gangrene is just dead tissue because of, and in this case, the dead tissue will be because of a blockage. Okay? You will see what they call Janeway lesions. These are painful hemorrhagic lesions in the palm and soles. Okay? So these are evidence of septic emboli as well. Painful embolic lesions or hemorrhagic lesions. All right? And you can get conjunctival hemorrhage. You can get splinter hemorrhage if you look in the nail beds. If you look in the nail beds, you can see these red spots in the nail beds, and we call those splinter hemorrhage. Osler nodes, these are painful lesions on the distal fingertips, okay? And then rot spots, these are lesions on the retina. So these are some of the signs and symptoms. What are some of the common cause for infective endocarditis, the bacterial infective endocarditis? Staphylococcus aureus, because these are bugs that reside usually on the skin. So that's one of the more common organisms. Streptococcus viridans, another common organism. Coagulase negative staphylococcus, now the fairly common, and Pseudomonas aeruginosa. So these are some of the more common bacterial causes. Strep bovis, Clostridium septicum, and then we have a group of organisms we call the ASIC group of organisms. So it's an acronym which stands for Haemophilus, Actinobacillus, Cardiobacterium, Encanella, and Kingella. So the ASIC group of organisms. So these are the more common bacterial causes. You can also get fungal cause. And the more common ones are Candida albicans, Histoplasma capsulatum, and Aspergillus. So patient comes to you and they febrile, they have a temperature, they look sick, they tell you that they're weak and lethargic, have night sweats, and they may even tell you that they're intravenous drug abuser. How do you make the diagnosis? So we have what you call major criteria and minor criteria. And we're going to go over what these major and minor criteria are. But to make a definite diagnosis of infective endocarditis, you need 2 of the major criteria. Or you can use 1 major and 3 minor. Or if you have 5 minor criteria, that definitely makes the diagnosis of infective endocarditis. You may just have 1 major and 1 minor. That would make it a possible diagnosis, not definite, but a possible diagnosis. And then just 3 minor will give you also a possible diagnosis. So you have to be clear how you're going to make this diagnosis, and what are the criteria for a definite diagnosis and a possible diagnosis. So again, for the definite, you need 2 major, or 1 major, 3 minor, or 5 minor criteria. So let's look at the criteria now. So the major criteria is if you have positive blood culture. And it's not only, positive blood culture. It has to be with the typical organism from separate sites. Okay? You might have, because when we do blood cultures, we do multiple blood cultures. You can get contaminants. So one of them may be positive. Just one blood culture may be positive. If you have something like infective endocarditis where the blood is seeded with organisms, all blood cultures should be positive. Okay? So, if it's a contaminant, then if you're careless, then one of the culture medium, will be contaminated, and then the others will be okay. So positive blood cultures with the typical bugs from two or more separate cultures. So that's one of the major criteria. The other major criteria is positive echo features. And the positive echo features are vegetation. So if you see a nice big fat vegetation, that's a major criteria. If you see evidence of abscess on the echo, that's another major. Partial dehiscence of a prostatic valve. So if the patient, say, had a prostatic valve in the past, and then you see this prostatic valve rocking, or it may be dislodged. Okay, so it may be rocking or dislodged. That is also another positive sign for a major criteria. And then new valvular regurgitation. That is if you did an echo on the patient, say a couple of weeks ago, and then patient comes in, and then you do the echo again, and you see rip roaring, say mitral regurgitation or tricuspid regurgitation. So you may be dealing with a vegetation which caused that. So you have to know the major criteria, and the major criteria is basically blood cultures and echo features. Okay, and so for the echo, we talk about vegetation, abscess, fistula as well, partial dehiscence of a prostatic valve or a new valvular regurgitant murmur. And then for the minor criteria, we have a bunch of the minor criteria, but if you have enough of them, you can have a possible and a definite diagnosis. So the minor criteria, if the patient have had, I'd say, a predisposing cardiac lesion, say for instance, the patient has had a rheumatic mitral valvular disease in the past, then they're at a setup or increased risk for endocarditis. So predisposing factors. So previous cardiac lesions such as rheumatic or a bicuspid aortic valve, something like that. If the patient is an intravenous drug abuser, that's also a predisposing factor, one of the minor criteria. And then evidence of embolism, that is the breaking off of the infected material with distal propagation. So if you have the patient have, say, a CVA embolization to the gut, to the bowels, or the lower extremity, pulmonary infarct, because if the patient had, say, a tricuspid vegetation, and this tricuspid vegetation break off, it can travel to the lung and cause infarct. That is, a portion of the lungs would be necrotic, would die because of the blockage of the blood supply. Conjunctival hemorrhage. So these are evidence of embolism. Fever greater than 38 degrees Celsius is another minor criteria. Also, immunological problems such as glomerulonephritis or the Osler nodes. Remember, we said the Osler nodes are painful lesion on the distal aspect of the fingers. Positive blood cultures that do not meet the major criteria. So remember, for the major criteria blood culture, you have to have positive cultures from separate sites. Okay. For a minor criteria, you might say if you did 6 blood cultures and 2 of them and 4 of them come back, say, positive, you may have a minor criteria there. So, these are the minor criteria. So you have to know your major criteria and your minor criteria. Again, for your definitive diagnosis, you need 2 major criteria. Or you can use 1 major criteria and 3 minor, or 5 minor criteria. Okay? So these are some of the lesions. The Osler nodules, remember, these are painful lesions on you can have it on the fingertips or on the sole. Okay? It's a minor criteria, however. But you may get something looking like this. Patient have a nice big vegetation on the tricuspid valve. And if it was in motion, you should be able to tell, is it on the septal or the anterior leaflet? Okay, so you when you're reporting on the location of the vegetation, you have to say definite where is it located. All right, and then M mode would also help you to, if you see something looking like this mitral valve looks a bit thickened, shaggy, so there may be a vegetation or something going on there. All right, so this is a transthoracic echo, and then if you look at it, all right, it's not gonna play, but you look, the mitral valve looks a little bit thickened. Not sure what's going on there. So and again, you have to get multiple views, okay? Multiple views. Just getting one view is probably not going to be helpful. So you have to get multiple views, looking at, see what's going on. And you may even need to get a transesophageal echo, because the transesophageal echo going to have much better resolution, spatial resolution, so you can see clearly. And not only that, but if the patient have complications of the infective endocarditis, such as abscess, fistula, you can also see that on the transthoracic echo. Okay, so it's very important. All right, so didn't play. This is a patient that we actually had who her presentation was a little bit different. She presents with an acute non-ST segment elevation myocardial infarction. So she presented with a heart attack, but she was septic. She had evidence of infection, and we did the transthoracic echo. There's some suspicion on the mitral valve, and then we go on to do the transesophageal echo. So she had a vegetation on the mitral valve, and apparently this vegetation broke off and traveled through the coronary system and obstruct the coronary system, and she had a heart attack. So, sometimes you get all sort of presentations. So, all right. So again, you may need a transesophageal echo if your clinical suspicion is high and the transthoracic echo is not very helpful. All right. So the important thing is to know how to make the diagnosis. You have to know your major criteria, your minor criteria. All right. And then, when you see a vegetation, you have to state clearly the location of the vegetation. So you have to know the anatomy. So what are some of the complications of infective endocarditis? Remember, this is an infection. So with infection, you can get abscess formation, you can get tunneling, the infection can get larger and obstruct, the valves can distort the heart. So we divide the complications into cardiac and then extra cardiac. So what can occur inside the heart, and what can occur outside of the heart. So inside of the heart, again, it's an infective process, so you can get destruction of tissue. So the valve you can get multiple perforation or perforation of the valve, destruction of the valve. Anything sits on the valve gonna prevent proper functioning of the valve. So the valves usually become regurgitant. If it's a large enough vegetation, it can obstruct the valves and you can get stenosis. For prosthetic valves, the important thing there is dehiscence, because remember, you have to sew these prosthetic valves in place. So you have to sew them in place. And if the whole thing becomes infected, then the sutures can rupture. And so the valve you can have dehiscence of the valve. The prosthetic valve can be dislodged. Okay? So be aware of that. So prosthetic valve dehiscence. Again, abscess, wherever you have infection, you can have abscess, fistula, aneurysm, pericardial effusion, heart failure. If you have, say, significant regurgitation, you can get heart failure. Extracardiac complications that outside of the heart now, you can get embolization of the infected material, travels to the brain, and you get what we call cerebral embolization. The patient presents with a stroke. Okay, so be careful of that. Be aware of that. Sorry. You can get systemic embolization. That is, the infected material can embolize to the bowels, so the patient can present with infarcted bowels, or it can go to the lower extremity, and you can have problems there. So the transesophageal echo is very important to look for if you have very small vegetations, or if you have abscess and fistula. Your transesophageal echo is very important because it has a higher spatial resolution, both lateral and axial resolutions. It has a much higher spatial resolution than your transthoracic, higher sensitivity and specificity than your transthoracic. And in the evaluation of prosthetic valve, your transesophageal echo is better for that. So if you have high-risk patients and you suspect complication, it's best to go with your transesophageal echo. If the patient looks like endocarditis and behaves like endocarditis, and your transthoracic is negative initially, you may want to repeat it in about 7 to 10 days, okay? Because the process may be an early one, and then after 7 to 10 days, you may see a nice big vegetation there. So, so that concludes our lecture on endocarditis. It's important that you understand, the important thing there is to recognize the vegetation, okay? You have to know how to make the diagnosis. Okay, making the diagnosis is very important. So it's a modified Duke criteria. Okay, for definitive diagnosis, you use 2 major, or 1 major, 3 minor, or 5 minor. So you have to know the criterias. Okay, and then the complications. All right, so once you know these, once you know this, then you should be fairly comfortable